Hello, good afternoon, everybody. My name is Elizabeth on behalf of NAC. Thank you so much for joining us. It is 3 p.m. Eastern. We're going to go ahead and give this about 10 more seconds before we get started. You should be able to see slides on the front of your screen. You should be able to hear my voice. Let's go ahead and give it 5 more seconds before we get started. Good afternoon. Welcome to session 5 of Optimizing Use for the Expanded Care Team for Hypertension and Cholesterol Management. This is our 5th session of the Million Hearts Learning Lab series. My name is Elizabeth Breidenbach. I'm a meeting and event specialist based in the Clinical Affairs Division here at NAC, and I'm pleased to bring you this event along with my division colleagues. Before we get started, let's review a few housekeeping announcements. You have joined this online event by either physically calling in or using computer audio. All attendee lines have been muted and will be muted for the duration of this event. We do have the Q&A box located in the lower right-hand side of your computer screen open for the entire session. Simply type your questions, comments, or concerns into this box. Make sure you hit the send button. So important that you hit that send button. That's how we get your questions into the chat. We will answer questions at the end of today's session in our very robust Q&A session. So again, please dump those questions into the Q&A at any time. If for some odd reason we cannot answer your questions in the time allotted or need additional resources, we'll make an attempt after the event has been completed. Friendly reminders that today's event is being recorded and all attendee lines have been muted. At this moment, I'm going to turn things over to Meg, who's going to be introducing and setting the stage for you guys. Meg, the floor is yours, and I'm sending you the WebEx controls right now.
Thank you so much, Liz, and thanks to everybody here today. Welcome to our 5th Million Hearts Learning Lab opportunity on optimizing the use of the expanded care team for hypertension and cholesterol management. I'm Meg Metter, Director of Clinical Integration and Education with NAC, and I'll be moderating today's session. So just a little bit about our learning labs if you're not familiar. The total time is 60 minutes, the same as a traditional webinar, but it's packaged into 3 pieces. So we have a pre-work audio recording, a pre-work survey to gather your questions in advance of today's live event, and then of course today's event, which is about 45 minutes. We hope you've had a chance to listen to the pre-work audio recording, but if not, this is an excellent short podcast that can be used for training and your clinicians and staff, and we encourage you to access it and share it out and use it well beyond today's event. As I said, our live event will be 45 minutes, and we'll be sharing at the end of the call how you can apply for CME credits. These are our learning objectives today. So a lot here focused on how to leverage and use your expanded care team, various roles effectively and optimally. We're going to identify key components of patient management models that enable successful medication therapy management. We're going to talk about some communication strategies that facilitate clinical action and enhance patient engagement. And we'll talk about some of those workflows for using the expanded care team. We have 3 stellar faculty that I'm honored to introduce today, all who are leaders and pioneers in their health centers. First is Mary Blankson. She's the Chief Nursing Officer with Community Health Center, Inc. in Connecticut. We've then got Jasmine Mencia, who's a pharmacist with Berks Community Health Center, and Diane Fisher, chronic disease telehealth nurse, also at Berks Community Health Center, and that's in Pennsylvania. So at this time, I'm going to turn it over to the great team who will be sharing a little opening summary, and then we're going to go into the live Q&A session.
Wonderful. Thank you so much, Meg, and wonderful to be back with the Million Hearts and for this learning lab today. I'm just going to briefly summarize a couple of the items that we talked about during the pre-recorded session that you reviewed. The first of which focusing specifically on stratified approaches to chronic disease care. So really this is about sort of when you choose a chronic disease, how do you make sure that you can affect change on the total population without necessarily overwhelming your care teams, right? Oftentimes when we are trying to improve, whether it's hypertension measures, diabetes, or other chronic diseases, we tend to choose a subpopulation and we work on things sort of one at a time because things can be very overwhelming and it can be extremely challenging throughout the course of even just delivering routine primary care, right? So when you think about a stratified approach, we really sort of support three particular steps that you should be considering when doing this. So first, consider your population. Are there obvious groups that can be looked at separately to ensure that there's a best fit solution for that group? So the example that I've put on the slide today is specifically for uncontrolled hypertensive patients. Could they be stratified into patients that are on no agents, patients that are on a single agent, and patients that are on two or more agents? This will sound familiar to participants in the Million Hearts program as well. Then you want to think about what are the solutions that could be employed with each group. Then consider your team. So this is step two. Who do you have on your team? Can you allocate team members to different groups or different interventions so that they can complete the work without necessarily being overwhelmed or having to support the intervention with all three groups? So again, you want to make sure that, potentially for the group with no agents, maybe that group is assigned to a pharmacist or a nurse to review those patients, have them come in for repeat blood pressure measurements, and to actually formalize and start them on their first evidence-based regimen. You might even be able to do this with a single agent as well. And then for two or more agents, you may then leverage your primary care team or potentially an e-consultant or a cardiologist or other individuals on the care team to support this. So again, the goal is not to overwhelm any particular one group on your team, but to make sure that you are trying to affect change in your total population simultaneously so as not to delay the types of changes we want to see for our patients. Step three is simply to think about evaluation, right? So for those individual groups, how are you going to measure that group or that intervention is working? So much like any other quality improvement, being held accountable for the work that they're doing, and that we can be aware of, is that intervention successful? Next slide. The next approach I want to talk about is proactive communication to support specific interventions. And really, scripting is so very important, even when it comes to interventions for licensed staff like registered nurses. And the point of it really is to create a culture of proactivity, right? So I put some examples on the slide here as well. So again, when the nurse is potentially coming to the provider to talk to them about their interactions with a hypertensive patient. Hey, provider, I sent the prescription for the self-monitoring blood pressure cuff. I've started lifestyle modification with smoking cessation. I've also referred them to an RD to begin work on salt reduction, and then deliver the specific ask to the provider. Maybe for a patient on no medications, which medication would you like to add, right? We're already telling the provider that we've collected the other data for them. We already know for this particular patient that they really need to be on a medication. So let's ask that question, right? If we want the desired results of the patient being on a medication, because we know that that's the evidence-based intervention, we want to ask the right question. For folks who are on a single agent, maybe the question is, which medication would you like to add to get them on that dual agent intervention? And maybe for those on 2+ agents, the scripting could be, would you like to add a medication, or would you like me to coordinate an e-consult or referral to cardiology? Oftentimes, again, if you build scripting and if you build sort of standing orders that really support your nurses or other staff members to be proactive, they can really be more pointed about the questions that they're asking, which will lead to higher satisfaction for your providers, as well as for your teams who now get to be more involved in the care of the patient. Next slide. I did put here just definitions for RN standing orders and delegated orders. So again, standing orders are orders that apply to a large population of patients. So for example, a hypertension standing order could look something like, here's the minimum data set that our staff members will collect on every single hypertensive patient when they come in, maybe for an independent nursing visit or a group visit or whatever other specific type of visit outside of a visit with their provider. And these are the items that must be addressed. And here is the menu of other items that a nurse or another staff member could complete. Versus a delegated standing order, which is for a specific patient, where a provider may open a telephone message and say, hey, I saw Mr. So-and-so today. I checked his blood pressure. It was still elevated. I started this medication, but they're going to come back and see you again in 2 weeks. If the blood pressure is still elevated, please go ahead and increase that regimen to this. If it's fine, then just have them schedule a follow-up with me 2 weeks later. So again, sort of delegating care to another licensed staff member, thereby increasing primary care access and still making sure that this patient is getting the care that they need. The nurse can then, or other staff member can also do education and other interventions as they try to raise the health literacy of the patient involved. Next slide. So again, I always want to talk about using data as well. So here's some strategies. One called the by any means strategy. So this is an example of a dashboard that we use at Community Health Center Inc., where we identify patients that are coming in person for either dental visits or behavioral health encounters that are sort of considered non-medical visits, where there's actually medical intervention that is required for this patient. Maybe they have an uncontrolled blood pressure or an uncontrolled A1C. Maybe they need a retinal screen, whatever the case may be. But really thinking about how do we leverage the time while the patient is in the health center. This way, you can actually have proactive staff that will sort of work with and offer services to patients who are already in the building to make sure that we can fill medical schedules or potentially to fill an already existing schedule. At CHC, we utilize nursing to do this. But again, depending upon your state and your billing model, it could be any particular type of staff that might be able to bill a 99211 visit or potentially queue up the visit for the provider to just come in the room for a few minutes when maybe they had a no-show in their schedule. And not only is this a satisfier for the team, because again, their schedules are more able to be managed in terms of filling in those no-show spots so that they can really meet their budget expectations, but also a huge satisfier for our patients because they really continue to see us as a one-stop shop. Next slide. And this is another example. This is our medical assistant dashboard that we use to close care gaps for patients. So again, really making sure that the care team has all of the data that they need. They don't have to go hunting for it or find it manually, but they have an electronic tool that says to them, these are the items that are due for the patient today. And they can actually be proactive and they can go ahead and work to close those care gaps and make sure that we are continuing to follow up on all of the things that are important for the patients today. So Meg, I'll turn it back to you. I think we're going to have our Berks friends talk a little bit about their SMBP program.
Absolutely. Thanks, Mary. Yes, definitely want to turn it right over to Jasmine and Diane. Thanks.
Good afternoon, everyone. I just want to walk you through our workflow here at Berks Community Health Center and kind of give you an idea of how our expanded care team works together to help our hypertensive patients. So basically, this is our visit module. I'm just going to kind of go through what we talk about at each visit. So at visit 1 is when we basically get acquainted with the patient and collect pertinent information that helps us assess other factors that may be contributing to their hypertension. Things like smoking status, salt intake, caffeine use, as well as their current diet and exercise. We take all of that account during visit 1. We also review their past medical history since certain comorbidities will lead to certain clinical decisions. However, a majority of our visit is spent training them on how to use their Sphygmo-compatible blood pressure cuff and the Sphygmo app, since these are things that will help us guide our clinical decisions in the future. Therapeutic recommendations may or may not be made during this visit, simply because we're going to see them again in 1 week. So unless they're in hypertensive urgency or emergency, then we will obviously try and make med changes ASAP, but typically they can wait 7 days before us making a recommendation. So during visit 2, which as I mentioned, occurs 1 week later, we review their at-home blood pressure readings and we make sure that their numbers are coming through the app. We also make sure that they are measuring their blood pressure using the appropriate technique. So during this visit, we kind of let them run the show and they show us how they put on the cuff and they take their blood pressure for us here in the office. If retraining is needed, we will provide that at this time. And then during this visit, we perform a medication reconciliation. So we have the patients bring in all of their medicines, not just their blood pressure ones, and we go through them one by one and ask the patient how they're taking them and if they know what the medication is for. Obviously, sometimes this is when we identify adherence issues or we realize that they're missing a medication. So all of that information obviously helps us make a better recommendation to the provider and work with the provider to help get this patient to goal. We use Athena Practice here at Berks Community Health Center. So a phone note is typically used to communicate all medication reconciliation findings with the provider. And this is when we typically will make a therapeutic recommendation if the patient's blood pressure is not at goal. Typically, we will schedule a follow-up visit in 2 to 3 weeks. This allows the provider to read the note, assess what we've found, prescribe a new medication, and then allow the medication to work before we assess if they need additional changes. So at visit 3, that's pretty much what we do. We will evaluate drug therapy and see how the changes that we've made have helped their blood pressure. We'll also address possible side effects that they may have experienced by the medication changes we made, and we just make sure that they're doing well overall with the new regimen. We typically try to review the food label as well during this visit, since we know that most of these patients have comorbidities like diabetes and high cholesterol. It's always good to review the food label and teach them what components they should be looking out for and portion control. So visit 4 and on is basically a repeat of visit 3 minus the food label reading. So basically we will just continue to monitor them until their blood pressure is controlled. And then once they're controlled, we can pretty much switch over to telemed and just monitor them remotely as long as they're using the Sfigmo app and keeping up to date with their readings.
Thank you so much, Jasmine. Really a wealth of information. And I think, there's such interest in SMBP across the country now. It's a great use case for showcasing what the expanded care team can do. So let's dig into that a little bit. I want to share with this group some of the questions that were posed in the pre-survey that I'm going to ask of our great presenter panel here today. And we're going to start with a really general question that I'd like to pose to all three of you, starting with Mary, then Jasmine, then Diane. So in your thoughts and your thinking, what is the impact of using an expanded care team? How can it benefit the patient?
It really benefits the patient in a lot of different ways. I think oftentimes the support team members do tend to be more socially concordant to the patient communities that we're serving. And so again, there is that connection, at that more personal level. It also gives the patient an opportunity to sort of hear about and learn about their chronic disease in a lot of different ways. A provider doesn't necessarily always have the time to be able to answer, the 101 questions that may come up. And also, each care team member really has their own unique skill set that they bring to the table, and we want to make sure that that's leveraged. Providers, can't do everything perfectly, right? There are things that MAs do well, there are things that nurses do well, and pharmacists do really well that are unique and different from that of a provider.
Thanks, Mary and Jasmine. You certainly have your unique specialty. So from a pharmacist perspective, the same question.
Yeah, so I mean, an expanded care team can obviously be made up of a variety of different practices, but from a pharmacist perspective, pretty much we're helping get the patient to goal sooner. So as you know, most providers have like a 1 month or 3 month follow-up. And by having this expanded care team, we're able to follow up with the patients a lot more frequently. So as you saw between visit 1 and 2, it's a 7-day follow-up for us. And then after that, a 2-week follow-up basically until we get them controlled. So we're really helping the providers get their patients to their goal and a lot sooner than they probably would be able to do on their own. And not only are we addressing, just hypertension, but the other major chronic disease states like diabetes and cholesterol. So in the grand scheme of things, I'd like to think we're helping prevent, those big cardiovascular events like heart attacks and strokes that may have came if they really did wait until their designated appointment time.
So important and impactful. And to those who didn't catch it when I was introducing her, Diane Fisher is actually a chronic disease telehealth nurse, which is a new position created out of the pandemic. So definitely want to hear from you, Diane, in terms of your perspective. What is the impact of using an expanded care team? Did we lose you, Diane?
She might be muted.
Sorry about that. So from my perspective, I tend to be more on the preventative care, like with Jasmine, I defer to her for medication, expertise. I tend to look at the other members of our expanded care team, like social work, I will refer them to them if they have trouble getting their medications. Sometimes we don't know why they're not taking their medications. I will refer them to nutrition. I will refer them to behavioral health, so that we're looking at the whole picture of trying to get them to goal, and not just, the medication part, which is definitely the ultimate most, important thing, but also why are they not doing it? As part of our medication reconciliation, we look at that. Why are you not taking this medication appropriately? There's so many other components that go into that's what I feel like my expertise that I bring to the table is.
And I would just like to add, Meg, Diane doesn't give herself enough credit, but she has been very helpful as well with getting people caught up on their immunizations, making sure that they are getting their colonoscopies and mammograms at the recommended time. So all of that's helping us close care gaps that obviously all the health centers are being evaluated for. So Diane does a great job at all preventative care services.
Jasmine.
Thank you. So appreciate that, and so important. And I'm going to ask another question about the expanded care team in terms of how do you prioritize and improve care management for your more complex patients? So I'm thinking of patients whose engagement might be limited, patients whose readiness is low, or maybe have adherence challenges, patients with low health literacy. So that's kind of a laundry list. I'd like to point that to you, Jasmine, and just what are your thoughts about how the expanded care team could really help with those types of patients?
Yeah, so I mean, especially here where we work, we have a lot of patients who are homeless or, have financial difficulties or don't speak English, or exactly low health literacy. So honestly, what I have found is I truly believe that these patients who are not really engaged, it's for one of the following reasons. One, they don't understand their provider or the significance of like their disease states, like what could actually happen to them if they don't take their medications or they let it get any more out of control. Number two, sometimes they don't feel heard by their provider. And like Mary mentioned, providers only have so much time. So yeah, sometimes the interaction can feel very rushed. So by having the expanded care team where we can really sit down and listen to them and address their needs, I feel like they're more open to telling us the truth about things. And then three, they kind of sometimes feel hesitant to just ask their providers questions due to those rushed experiences or language barriers. I always find that visit one for us is like the most crucial, since that's where we're really establishing that bond between them and ourselves and letting them know that, hey, we're here to help you and we really want you to meet your goals and not end up with more problems. And I think just by showing them that care and letting them know that you're invested in their health, I almost feel like they then become invested in their health and realize, oh, okay, because there are so many times, especially as a pharmacist, I mean, I will just call them out straight on their lies, like, hey, you have a bottle here with 90 pills in it, and it was filled 4 months ago. Like, so you're clearly not taking this medicine. Why? Or, oh, and then they'll tell me the truth, like, oh, I don't know why I need that in the first place. Like, I don't even know what that medicine's for. Like, they'll always tell me, like, oh, I'm definitely taking my diabetes medicine or my hypertension medicine because they understand the importance of that. But sometimes the cholesterol medicine kind of gets pushed to the side and they don't really get it. So just by taking the time to explain to them how everything goes hand in hand and how it's helping reduce the risk of heart attack or stroke, you say those words to them, then they understand the impacts. And then also, of course, just using, layman's terms and try to teach them about the disease state and what the medication's actually doing for their blood vessels and helping the blood flow more freely and not be this clogged little artery. I don't know. Like I said, they get that buy-in. So patients can be difficult in summary, but I think if you just take the time to understand where they're coming from and take the time to explain to them all the things that they need to know about their health, they will come around for you and they'll actually surprise you.
So what I'm gaining from all of this discussion is really the importance of having the right team. So in your thoughts, I'm going to direct this to Mary. What are key considerations when developing and implementing an expanded care team? And then I have a follow-on question with that too, which is about how you communicate information among the team and then to the patient?
There's definitely a lot of considerations. And I think first, it's really understanding that you do have to have the structure and culture to support it. And I think that's really what takes the majority of the work. Right. So hiring providers when they come in the organization and telling them that, when you come to work for us, you are working for an organization where the care team is going to do things on your behalf without asking your permission, because we believe in team-based care and we know that this is evidence-based in the way things should be. But we are going to promise you as the provider that we are going to heftily train our staff. We're going to hold them accountable. They're going to get clinical scorecards. There's going to be evaluations for them, and direct oversight for them. So many organizations that have sort of the most advanced team-based models of care typically have clinical leadership that are directly responsible for the support staff. Nursing, whether it's a nursing leader or some other type of leader that really sort of takes on that larger challenge. And oftentimes they will be the ones who will collaborate directly with the chief medical officer to write standing orders, to interact with the providers and ask them, gee, we're interested in implementing some standing orders for this and this. What do you think? And again, you can't ever let perfect be the enemy of the good. So, I've had times where I've implemented a standing order, maybe 75% of what I've really wanted the nurses to do. But as they have then built the trust of the providers say, I'll let them do the other 25% because I see that they're well trained. I trust them. I have confidence in their practice. And I see how this benefits me as a primary care provider.
So you talked about culture, and I think, with CHC Inc., where you work, that is for sure the culture. So when you hire people, that's the expectation. But what if I'm an attendee here today? I'm at a health center where that isn't the culture, but I want it to be. How do you get provider buy-in on using the expanded care team to the top of their licenses? For example, using those standing orders or delegated referrals you talked about earlier.
Yeah. So it definitely is very tricky when you first start out because oftentimes, you want the providers to have confidence in the team, but the team doesn't yet have confidence in themselves, right? So a lot of it really starts with the team and training them, building their confidence, getting them excited about the things that you want to do down the road, and then really engaging like one or two provider champions to really being willing to test these so that they actually can be that champion and share with the other providers, hey, this is going really well. And, this is what has worked for me. And I think the other thing is sort of the general pieces of culture that we need to change as an organization is first making sure that we're moving towards a measurement-based culture, right? Whether you have value-based arrangements, whether, you're in some kind of accountable care model or things like that. The reality is that we need to be able to measure things, right? And data is a part of every team member's life. So you need to make sure that you are putting data in their hands, that they're understanding that they are going to be evaluated based on their performance, not in a punitive way, but in a we want to deliver the best care possible way, right? We're a team and we really want, I as the medical assistant, I as the nurse, I as the pharmacist, I'm in panel to these patients and it's my job to take good care of them too. I'm not just impaneled to like the provider, right? I have actual patients that I am responsible for. And then the other thing is just sort of gatekeeping, right? And again, a lot of that, as I said before, starts at the point of the interview to say that, we have a model of care here, and this is the model of care that we subscribe to. This is the direction that we're going. If you can get on board with that, then great, right? We don't want to take provider autonomy away because everything that we do with care teams is based on evidence, right? And these are the areas where providers sometimes are challenged to implement that evidence basis because there's just so many more chaotic things going on in our patients' lives.
Super. And I want to direct this question to Jasmine because we know using clinical pharmacists is such an important, impactful evidence-based strategy to improve outcomes in the cardiovascular space, but sometimes not used to the capacity they should be. So how do you get buy-in from your providers to use their pharmacists?
So I will say provider buy-in can be challenging, especially from a pharmacist perspective. Pharmacists have become an integral part of the expanded care team, but some people are still learning what our true capabilities are or what our true understanding is of the disease states, as well as obviously the medications. So, just speaking from experience here, especially in the beginning, getting that provider buy-in was difficult because A, I'm a new hire, so it's not even like I have a prior relationship with them. And then B, again, most people have that stigma of pharmacists, like, you count pills. That's my job. I don't know anything else. But once the program really got up and running and, we start making these recommendations and they start seeing the values, because I can't make up blood pressure numbers. And when their patients are coming to them for their 3-month follow-up and now their blood pressure is controlled and they see, oh, hey, they're enrolled in the SMBP program, it's like, oh, this is kind of actually working. And then you build those relationships with those providers, and now, we can't stop them from referring to the program. So our program has really taken off. They've really embraced me and my recommendations. Honestly, we've probably reached the point that if we were to write a standing order, I could probably make the med changes myself, because very rarely does a recommendation not get done at this point. So yeah, and then like I said, with any relationship, time and just trust and seeing the actual outcome, that's what really gets them. And then of course they start talking to their other provider friends and like, oh, you should recommend them to Jasmine. And now here we are, full blown, and enjoying every bit of helping everybody, including the provider, because it also takes stress off of them, which they've expressed to me.
Super. I'm going to throw a monkey wrench into this because we have such a good amount of questions in the chat or the Q&A, and I want to ask this question to the team. So we've talked about the important roles of the clinician, of the nurses, pharmacists, and the different players on that care team that can really enhance care. But the one person we haven't talked about is the patient. So there's a question posed that says, as we move forward toward equity in health and healthcare, how are you empowering the perspective of the individual patient to be a part of the decision-making of their wellness healthcare plan? So if there's somebody that would be willing to just answer this quickly about how do you bring that patient into the care team as well?
I mean, I could make a quick comment and then Mary, take it away. But quick comment. Anytime a medication change or any change to their therapy is going to be made, I honestly ask them and make them part of the decision-making process. So, hey, here are your options. We can either increase this dose, and I'm not, and I'll give them my honest opinion. I'm not sure if that's going to get us to where we need to get you, or we can add another pill. I understand that that's going to require you to take an additional pill per day. But, I think that's what might get you there faster, but we can go either way. What would you prefer? And kind of make them part of that. And same thing, especially, I know we're not really talking about diabetes today, but when it comes to like an injectable or a pill form, same thing, just engaging the patient and seeing what they feel most comfortable with.
Yeah, and I think that the main thing that I would pick up on with that, and we've done a lot of training, in particular with our nurses on this, around, making sure that you're not necessarily working harder than the patient is, right? Patient preference, patient motivation, all of this has to be a part of it. And this is why it's so very, very important for folks to have motivational interviewing training. I will say there are some excellent trainings on health coaching, motivational interviewing, and things like that that you can leverage very, very cheaply from many different organizations. Just to, with some patients, they may not quite yet be ready for change, or, maybe as was just pointed out, maybe they haven't been refilling all of their medications and would love to advance their regimen, but they're not even taking the current one, right? So we really need to work on med adherence. And so building your support staff's knowledge in how to have those motivational interviewing conversations, how to set goals with the patients, different resources and other things that they can troubleshoot around med adherence, but also understanding that, these are very valuable resources. And so if there is a patient that isn't quite yet ready for change, we, unfortunately may need to plant that seed of motivational interviewing and say, when you're ready, because these are the things I'm really worried about, like, you call me and I will be there in a heartbeat, but then they may need to move on to other patients. And I know that's kind of a hard message to hear. Trust me, I tell that to my nurses and they look at me like I'm speaking Greek, but it's just, it's very difficult, right? Not every patient is quite at that point yet. And that's why motivational interviewing is so important, because I believe every patient will get to that point as we connect dots to things that they care about, their grandkids, their own kids, their siblings, their a family member, maybe something happened in the community that you can, really connect them to why this is really valuable and why it's so important, that they think about, creating some change in their life.
Super. And I want to switch to Diane. I have a great question that came in with our survey around chart prep, but I'm going to ask you another question that came in through the Q&A about SMBP. I'm hoping that you can answer it, or Jasmine, really quickly, and then we'll ask the chart prep question. So this one is, what strategies do you use to introduce the recommendation to use SMBP and then engage and sustain SMBP for patients with hypertension? Do your providers introduce it initially? Do the nurses? How does that work in your health center?
Well, the providers usually refer them to us, and then when we bring them in, we talk to them about the app, and we explain to them how the app works in conjunction with transmitting the information to us directly. And once we explain that to them, even our older generations, like in the 70s and 80s, they get really excited. Like they just think it's the coolest thing that we can now do this. And like the fact that they don't have to come in so often. And that's what I always sort of put out to them. If we do it this way, you won't have to come in so often. We can actually communicate over the phone. We can monitor you from home. You can monitor yourself. These are the things that, how I introduce them, to the use of the app, that it really, you would be surprised how exciting it is for them to be able to utilize this program.
Super. Thanks, Diane, for answering that. And then I do want to ask you and go back to the chart prep question. So it's, what can chart prep look like, and how does it facilitate the patient visit?
Well, I mean, I have to give this back to Jasmine. She really did develop a really great key for us to follow, like a template. But we look at, oh my goodness, it probably takes me about, well, now it takes me about 10, 15 minutes to prep each chart now that I've gotten it down to boom, boom, boom. But we really look at their medications. And we look at allergies. We look at comorbidities. We look at recent lab work. Do I need to get a new lipid panel? We look at, of course, gaps in care. Have they seen a nutritionist? So then I sort of like try to look at their note real quick and see what they've touched. And then, of course, their flow sheets. What is the flow of their hypertension or their A1Cs? Are they up and down? Are they just sort of a little bit elevated? And that actually helps me see how soon I need to see somebody as well. Especially my no-shows. When do I want to reschedule them? Can they be pushed out? Do I need to bring them in as soon as possible to try to get them engaged? But a big thing there, like I said, is it takes me about maybe 15 minutes per person to prep, to look at those things and sort of put a picture together of things that I'm going to try to touch on in that first visit.
Super. Appreciate it. And then I have a question here that I'm going to pose to Jasmine. So who is responsible for the initiation, management, and augmentation of hypertension or cholesterol therapy?
So like I mentioned earlier, unless a standing order or collaborative practice agreement is in place, I mean, basically the provider is responsible for the initiation and any augmentation of the hypertension or cholesterol therapies. I know that there are some collaborative practice agreements that allow pharmacists to change doses. For example, if a patient's on amlodipine 5 milligrams and you decide that they probably would do better with 10 milligrams, I to get the provider themselves. I am functioning here in Pennsylvania, and Pennsylvania has some more strict laws versus other states that I'm licensed in. So getting that CPA in place and filed with the board and stuff can be a little challenging, but definitely doable depending where you're practicing, and definitely would make caring for these patients a lot easier too, because like I had mentioned earlier, it's very rare that they say no, or no, we're going to go with a different plan. So obviously just even that gap in time of waiting for the okay, that creates an extra phone call that I have to make to the patient, a kind of an extra explanation. Hey, we're going to increase this, so you need to stop this. I much rather prefer to do that in person to make sure that they fully understand. I'll mark the X on their bottle so that there's no confusion. But right now we're not there yet, but it's definitely something that can be done. And then, management can be performed by various team members, such as the nurses, the pharmacists. I mean, MAs can probably help too. Realistically, as long as there's a protocol in place, all clinical staff can play a role in helping manage hypertension and cholesterol.
And great. I mean, that's such a great way to sort of start to wrap up today's conversation, because that's the whole point, is that all of us on the care team can play really important roles and provide much more effective and efficient care to the patient. But the question that's floating in the Q&A, and my final sort of question to this group is, okay, well, how do we pay for it? That's what's in everyone's mind right now. This sounds great, but how do we figure out the billing? So how can health centers get reimbursed for using expanded care team members in this kind of way so that it's sustainable? So Mary, I'll have you share your thoughts on that one.
Sure. I mean, I think there's lots of different ways, and I have lots of partners in other states that don't have the same privilege that I have to bill a 99211 visit. Although I will say, check your billing regs in your state. Sometimes they don't explicitly say that you can't. And so again, they don't necessarily need to say like, yes, specifically you can, but if they say you can't, then you can't. If they don't say you can, but they don't say you can't, then in theory, go ahead and do it. And trust me, they will clarify later once they realize that there's some kind of a loophole, and hopefully they'll clarify for your benefit, which is what happened in Connecticut, where RNs in particular are identified as LIPs actually. But there certainly are other states that can bill a 99211 as well. But for states that can't, for example, a bunch of my colleagues in Colorado, they oftentimes will do what they call a nurse assist visit, or sometimes they'll do a pharmacy assist visit if the pharmacist, because in Connecticut, pharmacy can't bill a visit. And so oftentimes the pharmacist or the nurse or other staff member will kind of do the whole visit. They'll document everything. We'll create templates to make sure that it's a very complete visit. If it's an RN, then they do have the ability to quote unquote assess. So they'll put in all their assessments, all the data and information, the intervention that is chosen. And then again, it's important to develop that scripting. So then when you invite the provider to come in the room, there's no doorknob complaints, right? There's nothing that is going to keep the provider there to address chronic pain or address all these other things, right? We, the nurse or whomever can say, when the provider comes in, they're just going to review the treatment plan, or sometimes the nurse can even stay in there. So then the provider can literally just stand at the front of the door and say, here's what we're going to do. My nurse is going to wrap up with you. I'll see you back in a couple of weeks. You can coordinate your next appointment with me on the way out. And that can actually simply be billed through the provider schedule, because that care is actually delegated by the physician, nurse practitioner, PA, et cetera. So that's kind of the one main way that I would recommend. And there's lots of ways to do this. And most of our providers, I mean, if we look at our data, usually no-show rates run anywhere from about 15 to 25%. So this gives you that ability to kind of leverage some of that open time in their schedules, but without kind of bombing them with a really obscene, 20-minute visit that's probably going to be an hour because they have to address 40 problems. But this is really a quick, the team member has already curated the whole visit for them, and they can just come in and actually have some time enjoying looking at their patient and just saying like, look, my care team member has done such a wonderful job with you. I'm excited about this. I'm vouching for them, and I'll see you back in a couple of weeks. So it really helps to validate your team-based model of care and really get your patients used to the fact that the buck doesn't always just stop with me, right? There's other resources. So not everybody has to call to talk to Mary Blankson, but they can talk to Mary Blankson's nurse and Mary Blankson's MA and Mary Blankson's pharmacist. And so that is really, really helpful.
Super. I really appreciate all the great responses, all the great questions that were submitted today. We didn't get to everyone's question in the Q&A, but we're going to do our best to address those after the fact and send them out to you. But I do want to share a couple of items in our wrap up. So here are some resources that I think you might find helpful. These are hot off the press. So we have an article that just came out on how to use nurses to improve hypertension control and cardiovascular health. So, very apropos of our topic today, I encourage you to take a look. A brand new article about jump-starting self-measured blood pressure monitoring in the United States and addressing barriers. Definitely encourage you to take a look at that new one. And then if you're interested in collaborative practice agreements, the CDC has a great set of resources on their website and examples. So definitely encourage that link. And then we have some statin videos for you if you want to sort of have some ways to begin conversations about statins. And then a new resource that NAC just created called 80% Hypertension Control, a 3-pillar practical approach. And this is a great example of leveraging the expanded care team and getting great results from it. So definitely encourage you to access these. We're going to drop links in the chat, but we're also going to be sharing the slides out, so you'll have access to these links afterwards. And then I'm going to turn it over now to Caitlin Dean from the AMA, who's going to walk us through how to claim CME credit. Caitlin?
Thank you. So as you'll see on the slide here, it will walk you step by step through the process of accessing and claiming the CME credit for today's event. So you will visit the activity page at the link provided, sign into the AMA EdHub website. If you don't have an AMA account, you can create one for free. From there, you'll click the Start button. The activity code for today is actually hearts, so that will get updated before the slides are shared, but the session code for today is hearts. And then you will click submit, take your quiz, and select the appropriate amount of CME time to claim. And the deadline for claiming credit for today's activity is June 29th. So again, the deadline will be June 29th, and the session code is hearts. Then next slide. In order to access or download your certificate of participation, 2 quick, easy steps. Once you're logged into that same account on the EdHub site and you've successfully completed the evaluation quiz, you can click on your name, select transcript, and then you'll find your completed activity and certificate that you may download at that time. And next slide. Perfect. So our next event is July 20th, and it will cover multidisciplinary approaches to tobacco cessation, new models, strategies, and workflows. The registration link is on that slide, and we hope to see you there.
Thanks, everybody. Really appreciate your attendance today. Let us know what you thought. There's a survey that's associated with this, and we definitely want to hear from you. So thank you so much. Appreciate it.